Wonderful. Well, we're going to go ahead and get started. My name is Jason Remillard. I'm with Mountain Vista Senior Living Community here in Wheat Ridge, Colorado. Many of you that are on today may have learned about this presentation either online or you may have received a postcard in the mail to join us for it. So we thank everybody that's here. We've got quite a large crowd, so we'll go ahead without further ado and get started. So thank you all for joining us. We do have a very unique presentation today that really brings together the industry experts really across the spectrum of all senior care. I'll be introducing all of these experts here with you soon, but in the meantime, I really do consider this a one-on-one 101 course on senior care. So it's going to be a lot of information in a very short period of time, and by no means is this going to be you're going to know everything by the time you're done. But hopefully this course will kind of prepare you for whatever could come related to seniors and making sure that you've got the proper preparation to do so. I would recommend taking notes. Like I mentioned before, it is going to be a fast-paced course, so any notes that you might want to take, get out that pen and paper, have that ready to go. For those of you that will be sticking around to the very end of the presentation, there will be a free gift for you, so just hang tight for that, and that'll be on the very last slide for you. So welcome, Understanding All Senior Care Options. Again, my name is Jason. We're going to kind of touch base. This is just a little bit of an overview of what we're going to talk about today. It's going to include in-home care options. That would be things that might assist in-home. Home health, we've got an expert here today that's going to join us to talk a little bit more about what that's going to look like and how home health can assist a person. Then we'll go into some of those community settings, such as independent living or retirement communities. And we'll go into assisted living, the difference between assisted living and assisted memory care, skilled nursing, also known as long-term care. And then that will get us right into rehabilitation with physical therapy and occupational therapy. We also have an expert here from Hospice that'll talk a little bit more about what hospice options are available, as well as the difference between hospice and palliative care. Each one of our experts today will be providing just a very small indication of cost or how these types of care can be paid for. In many cases, it's very difficult to give a good price because it's really based on a person's needs, and we have to understand that as we get into those details. On the same screen, you'll see all of the different payer sources that we'll be discussing today, and each one of our experts may mention these terms. I'll just give you a slight overview of those before we get into it. You might hear the term private pay or private assets. This would be money that we see in the bank accounts. This would be the money that we would use to write a check or pay cash, that kind of thing. LTCI, or long-term care insurance, is another term. That is one where insurance can be purchased ahead of time before care needs are there, and to help cover some of those needs. We'll talk about which types of care might use that. Private insurance, this would be those of us that have maybe a Kaiser or a United Healthcare plan, Humana, Aetna. Those are different private insurance organizations that may pay for some of the care costs. We'll go into more detail here in just a moment on Medicare and Medicaid. There are a lot of people that really mix these two up and really don't know the difference. So we'll differentiate those for you here today. When we talk more about independent living, we may go into just slight detail about HUD or Section 8. This would be low-income housing for seniors. And then finally, VA benefits. There are some VA benefits, both for active veterans, their past veterans, and their spouses. So we'll go into slight detail about that as well. But let's start out here with Medicare versus Medicaid. This is one that really a lot of people miss the point on what's what. So I've given you a little a diagram here that just kind of gives you that overview. We'll start with Medicare. So Medicare is a federal government program that really is intended for medically necessary medical services. That could also be hospital care, certain medical equipment, and then under the Part D benefit, it could include prescription drugs, medications. Medicaid does require minimum income as well as assets to be spent down in order to qualify for Medicaid. So that would cover basic healthcare costs, such as long-term care. It can even cover things like vision and dental benefits. This generally does not have a premium, although in a long-term care setting, there could be a patient premium, patient portion, or there could be some out-of-pocket expenses for small things here and there. On the right, we've got the eligibility. Really, Medicare is intended for those 65 or older, or those that are currently disabled and unable to work. Medicaid, on the other hand, is intended for low income. That could be someone of any age, really, and those with disabilities. And there are some where overlapping occurs, where you've got a Medicare and Medicaid policy, and that would be for a low income person that is either disabled or over the age of 65. So I'm going to now introduce some of our industry experts here today, some of those that you're going to be talking with a little bit and hearing from today. My name is Jason, as I mentioned before. I'm the Director of Admissions and Marketing here for Mountain Vista Senior Living. We are a full continuum of care campus located in Wheat Ridge, Colorado. We offer every level of care other than hospitalization. That would be independent living, assisted memory care, skilled nursing, rehabilitation, and even a skilled memory care. We also have several other experts with us today. Our home care expert is going to be Saul Martinez. He is Amada Home Care president and co-owner for the Denver West and Fort Collins locations. We'll also have Joan Guerra, who's with Home Health, Encompass Home Health particularly. She'll be giving us some more insight on what home health provides. And finally, we've got Ali Espinoza. She comes with a vast experience in hospice care. She works with LumaCare Hospice, and she'll be able to provide quite a bit more information here in a moment. I do recommend anybody that has questions as we go along, please type those into the messaging here so that we can answer those questions for you at the end. We'll open that up to some of our industry experts to answer your questions. With no further ado, I'm going to introduce Saul Martinez. He is the manager and partner of Amada Senior Care Denver West in the Fort Collins area. He has a vast experience in home care options as well as long-term care insurance. Saul, thanks for joining us. We appreciate you educating us about some of the services that home care can provide, as well as where home care can follow. Go right ahead.
Okay, great. I'm just going to spend about 5 minutes here and kind of go over in-home care now that you can hear me. Apologize for that technology issue. So what is in-home care? In-home care, so some basic, sorry, 1 second here. So personal care with ADL, so help with med reminders, help with transportation to the grocery store or a doctor's appointment. If you need help with laundry, you need help with a meal prep, breakfast, lunch, or dinner, or help with light housekeeping, providing companionship, all of those, one of them or a combination of them, if you need help in your home with those items. It's in-home care is also known as non-medical care or personal care. What are some signals that you may need in-home care? Here are some basic ADLs. They call them activities of daily living that you may have, or a loved one or a spouse or a mom or dad that you may hear they need help with one of these. Bathing, dressing, toileting, transferring, being able to get in and out of your bed or chair with an assistance. If you hear of a loved one or your spouse is having issues with that, or even maintaining continence, not being able to control your bladder or bowel function. Those can be signals that you may need in-home care. What would be an example of an in-home care visit by a caregiver in your home? what are some things that a caregiver could do. So what would a visit look like? A caregiver would come into your home. They would change the linen. They would help you with a few loads of laundry, washing and folding them, possibly a shower assist, transfer in and out of the shower, dressing assist. They can help you with meal prep, make you breakfast, lunch, or dinner. They can do a little bit of light housekeeping, vacuuming the living room, cleaning up the kitchen after making a meal, and companionship. That's what a caregiver visit would, some example of tasks that would be included in an in-home care visit. How would you pay for the in-home non-medical care? These are the four most common payer sources. One is long-term care insurance. And Jason mentioned that as an option earlier as a payer source for in-home non-medical care. Another one is private pay, which with a credit card or personal savings. Also, there is if you have a VA benefits, the VA aid and attention pension is also another payer source. There's a couple others out there that you may hear about, reverse mortgage or exchange of life insurance policies. Those are out there as well, but the most common ones are long-term care insurance, private pay with credit card, or personal savings for in-home care. How long would a shift last? The average shift lasts about 4 or 6 hours, accomplishing those tasks we talked about previously. The services can be only as 2 or 3 visits, or it can last as long as 4 or 5 years. In the home, or continue on in an independent living community, you can continue these services in that environment as well. Most companies will have a minimum of 4-hour requirement, or will have surcharges for smaller shifts, less than 4 hours. Most families will start to consider an assisted living upon reaching 6 or 8 hours of care in the home or in their independent living community, or there's a significant declination of ADLs, of activities of daily living, that they may need help with, and that can occur at any time. In-home care or personal care may still may be needed during the transition into assisted living home for the first few weeks with the approval of the assisted living home. Some assisted livings may require personal care services later on in the care model, such as sitter or companionship, and certainly would consult with the home that you're in there. So Jason, that's a little bit of a brief update on in-home care. What is in-home care, and then what are some signals, and then how long does the shifts last, and then a little bit how you can pay for the in-home care.
Thank you so much, Saul. I appreciate that. Much better overview than I could have possibly given to you on that one.
Again, I apologize for the technology there issues.
Yeah, almost to be expected at this point. All right, well, we'll continue on here. As I was mentioning earlier, we have Joan Guerra. Joan is an area manager with Encompass Home Health. She focuses on assisted living and independent living communities. But since moving here from Chicago last year, she has really spent much of her time prior to that in orthopedics, sports medicine, and helping patients really live their life to the fullest. Joan, please feel free to enlighten us a little bit about home health, what kind of services are provided, and how home health can assist a person throughout their different care needs.
Good morning, and thank you. Home health can range from so many places, whether it is your home, if you're on services and you go to the hospital or in a skilled nursing facility, our area managers are able to work with your family and the case managers there to prepare for when you do come back home. We work in assisted livings and independent livings to make sure our goal is to keep you aging where you are at. Our goal is not to have you need to go to a skilled nursing facility. It's to keep you strong and with the ability to live your best life where you are. So there are times that we work with companies like Saul's to make sure that you get everything that you need to stay in your home. We have everything from nursing that might be there for wound care, We do medication management. So if you are on many medications, whether it's for heart disease, COPD, diabetes, whatever the case might be, a nurse can come in, educate you on all the medications that you're taking, and come up with a process that's best for you to make sure that you're taking all of your medications appropriately so that you don't under medicate or over medicate and have any issues requiring you to go to the hospital. We have physical therapists that can come into your home and assess your level of need, whether it's just to get you strong and back to where you need to be after an injury or a hospitalization, or maybe a surgery like a knee replacement. They also can come into your house and assess the safety of your house. So they might say, hey, you had this fall and ended up in the hospital. We can make this adjustment in your house, and now you're not going to have this problem again, hopefully. We have occupational therapists. They focus on making sure that you can perform the activities of daily living that Saul had talked about, and make them a little bit more functional for you. If you had some sort of surgery, they can come in and assess how it would be easier to shower. Do you need to have your a shower bar put up? Is that the easiest thing? Maybe a different shower chair, maybe a raised toilet seat, something like that. We have speech pathologists, speech language pathologists. So a lot of times they're called speech therapy. They don't just worry about how you're speaking. They can help you with cognitive issues. So if there's things that are difficult, you're having word finding issues, you're forgetting things, they can set up your home and work with your family to make sure that you're having the ability to still do the things that you can do independently, make them a little bit easier, make it more accessible. We have a medical social worker who can come in and discuss anything from insurance. They can come in and counsel family and yourself about places that you can live. If you can't live independently at home, they can help with paperwork for insurance, applying for different needs in the community. And then we do have home health aides. Home health aides are able to come in and assist with showering and things like that. But it's important to note that those home health aides can come into your home and independent living facilities, but cannot go into assisted living facilities. One other thing that I like to make sure that everyone understands fully, that this becomes one of those things that we need to differentiate medical skilled home health from Saul's company that does home care. We are a skilled service provider, so we cannot help with laundries, meal preparation, things like that, any cleaning. That would be a non-skilled company that would be able to do that. The only other thing that I'd like to point out about home health is that we are needing to differentiate what home health, when home health is covered. It's covered by Medicare, it's covered by VA. There's no cost on those. Medicaid does cover. We are not a Medicaid provider, so you'd have to look into what companies are Medicaid providers. And the cost for when you have a private insurance is very plan dependent. But what makes home health different than outpatient physical therapy or inpatient physical therapy is that you have to be homebound. So most people who are in independent living or at home, the requirement would be that it takes a good amount of effort. It's a taxing effort to go out of your house. So you can go to your doctor's appointments or you can go grocery shopping, but you get home and you're done for the day. That is what what the government or Medicare has created as a definition of homebound. So if you're able to go out for appointments and go out to visit friends and go out to dinner and do this and do that, it's probably more appropriate that you're going to physical therapy in an outpatient setting as opposed to home health. Someone pointed out, did I hear that you will not be able to go into assisted living? No, we can go into assisted livings and we can go into independent livings, and we do often. Home health aides cannot go into assisted living. So just our physical therapy, occupational therapy, speech therapy, nursing, and social work can go into our communities. So I think that's about it.
All right, Joan. Well, thank you so much again for doing that and giving us a good overview of how that is. One of the big pieces is really understanding that there is a difference between home. That's often a misconception that we see all around the board there. So that's really good informing us on that piece. The next one we'll kind of go into here is really going to be more along the lines of palliative and hospice care. So today we've got with us Ali Espinoza. Ali is one of the most vibrant and passionate hospice care experts in the Denver metro area. She has spent many years in the senior care, as well as currently a community liaison for Care Hospice right here in Denver. So Ali, thanks again for speaking with us today about hospice and palliative care options, where the services transfer and are able to be used, and then how they're able to be covered.
Can you hear me, Jason?
Yes, I can hear you now. Go right ahead.
Okay, thank you for that introduction. So my name is Ali Espinoza, and I am with Care Hospice. And I have been working in hospice since 2005 in the Denver metro area. And hospice is really, it's a focus on the quality of life, not the quantity. So it's really a philosophy of care when someone is not wanting to seek aggressive treatments and things like that. So I kind of look at it like an advanced level of internal medicine care. We're focusing on keeping a patient comfortable and not seeking aggressive treatments. And hospice is for anybody who a doctor will say has 6 months or less of life. That doesn't mean that they can't live past that 6 months. Oftentimes people do, and they can graduate off of hospice. We've had people that have come on and off of hospice for years, and we're able to care for them. What is covered under hospice? It's a Medicare benefit, so it is covered 100% by Medicare. And what's included in that is any medications that they take related to their primary diagnosis, supplies such as incontinence supplies, gloves, wipes, things like that, and any DME that they're needed. If they're on oxygen, if they need a hospital bed, all of that is covered 100% by hospice care too. And we provide hospice care wherever the patient calls home. So it can be in an assisted living, it can be in a regular home, it can be in a skilled nursing facility, independent living. We just go wherever the patient calls their home. Some indicators for hospice are when we start seeing increased hospitalizations or trips to the ER, people are not participating in activities, or they're withdrawing, they're not eating. Maybe we've seen a rapid decline over the past 6 months, an increase of weight loss, uncontrolled pain, or frequent falls. Some of those things are good indicators that someone might be, looking at getting on hospice. And so what happens when someone signs on to hospice is we have an interdisciplinary team. So we have an RN, a social worker, a CNA who's able to help with those ADLs. and a chaplain to provide the spiritual support for our people, and a medical director. So they meet weekly to talk about the trajectory of the patient and what's going on, tweak medications if needed, talk about decline and things that are going on both spiritually and clinically. And they meet to, how do I say this, individually care plan the treatment for the patient. So let's see. And they do that. So when they sign on, they come on for 90 days, and then they're recertified every 60 days. So as long as they continue to meet the Medicare criteria for hospice, they can continue to be on hospice care for long after that 6 months of the initial onset for hospice. And also, you'll hear the term palliative care. And so palliative care is, it's kind of like a pre-hospice. So maybe someone has cancer and they want to continue to do some chemotherapy or treatments. Usually with hospice care, they're not seeking any aggressive care. Whereas if you have palliative care, you can still do your chemotherapy and things like that. And you'll have someone that comes out to your home, and the different palliative care programs are designed differently. So some may come once every 4 weeks, some are once every 6 weeks. So you have someone come in, check your medications and things like that, and to keep you comfortable. So it's kind of like going to a doctor visit, except they come to your home. And it's paid for on an 80-20 plan typically. So there is cost incurred with that, and you don't get all the extra benefits, such as having a social worker. The things are, DME is not covered. You're not going to get your supplies covered or any medications covered. So it is strictly just paid for, basically as if you went to a doctor's visit there. And those are kind of like some of the differentiations between hospice and palliative care. So hospice is more focused on the quality of life and not seeking aggressive treatments, whereas palliative care, they can have that in conjunction with.
That was very informative. I know I learned to quite. So thank you again for switch gears a little bit. We're going to talk a little bit about the different community care options that are available for seniors. So we talked about some of the services that are available: home care, home health, hospice. These are all services, and some of them actually intermingle with the community care settings. So this kind of gives us a couple different visuals here of the different types of communities. On the left side, we've got kind of the start of senior living. That's active adult communities. This is really intended for a younger senior population, but people really looking for that intent to really get involved with a community versus being isolated. Then you can get into senior apartments and independent living communities. And then from that point, it goes into more of like a group home or assisted living type setting. Group home being more of a small residential style living space versus most other assisted livings would be more apartment style assisted. Memory care is really a focus on those with very progressed dementia. Not everybody with dementia falls into memory care or a memory care assisted, but certainly those with very progressed dementia. We'll get into more detail about that here in a little bit. Nursing facility would be like your nursing home, long-term care, that kind of thing. And then that in the same location, a lot of times there will be a rehabilitation part of that. So obviously, as you get from independent and then start graduating up, the costs go up, certainly, as you see on this diagram on the right. And then certainly the regulation and the amount of staffing and needs changes. So obviously the cost is going up because you're now increasing care, you're increasing staff members, you're increasing the amount of needs that you've got, and thus the care will increase over each different step of that continuum. So we'll start here with just kind of an overview of those different ones. Certainly living at home, we're seeing a lot more of this. Pretty much anybody that is familiar with this industry knows that people are staying home longer, and that is fantastic. Some of it's because they're completely independent, and some of it's really not due to their independence. It's more so based on getting in-home care. That's what Saul was talking to us about a little bit ago, and getting assistance with showers or bathing or laundry or maybe some transportation assistance. It allows a person to stay independent longer, and there's absolutely nothing wrong with that. But once we step kind of above and beyond that, certainly we've got independent living options we'll go into discuss there. But when we're talking about care, the next step is assisted living. And that's really a person that has some needs, maybe needs some assistance with their meals and their housekeeping and their laundry. It could be a person that's starting early in their lack of independence. Maybe they're starting to get some light forgetfulness, but otherwise handle everything perfectly fine. And sometimes we see these people are transitioning from living it and then coming into an assisted living setting simply than what they would currently be getting or would be affordable for them to get at home. Assisted memory care, again, we talked about this being an advanced dementia program. One of the main needs of an assisted memory care is that it's a secure environment. So a person that might be they would step outside, get completely lost and confused. That might be the best option for them. And then the next step from there would be into a nursing home or long-term care. This would be where an RN or LPN or CNA is really needed 24 hours a day, 7 days a week. So that really is the purpose there. We'll touch a little bit on independent living here. I'm not going to go into too much detail because really this doesn't include care. So independent living communities can have a wide range of available amenities. Some of them do, and some of them do not include meal plans, housekeeping, laundry, transportation. But almost all of these communities do partner with home care and home health services to get additional help in that independent living community. Now, you ask probably, well, we're talking about senior care. How does independent fall into that? Well, it tends to be a precursor to a lot of it, but even more so, we see independent living more as a socialization need. This would be a need to have somebody around to talk to and rely on. When you live independently at home, you don't always have that. So in an independent living community, generally you're around people your own age. You don't have little children running around, loud noises and that kind of thing. Fewer parties, from my experience being in senior living, much fewer parties than at apartment complexes and things. Now, this could be paid really in a couple different ways. Privately paid is the most common. That's how we pay for our mortgage. Everybody that's on listening, we pay for our mortgage or our rent somehow. That's how we would do that. But HUD or Section 8 could also be an alternative to that. Next step from there would be the assisted living community. This is a community that offers 24/7 care, but these are not generally your licensed caregivers. These are going to be caregivers or QMAPs. QMAPs are who are certified by the state to pass medications based on physician's orders. So everything that's done in an assisted living setting is done under that oversight of a physician. Usually over your caregivers and your QMAPs in an assisted living setting, you'll have a nurse. That could be an LPN or an RN, but you'll always have a nurse overseeing their care. In an assisted living setting, the care is completely customized. No two people are alike, so their care would be customized individually to those needs. Assisted livings, being a healthcare community in and of itself, do have healthcare physicians, podiatrists, dentists, dermatologists that round the community. It out for transportation, and when mobility becomes a challenge, that tends to be a much better option, having those services come into them. To provide 3 meals a day, lots of activity and engagement socialization side of that. Medical appointments or to out of entertainment. And a lot of assistance for those with. There are two types of assisted livings, those in a group residential care home. That tends to have a little bit smaller of an environment, but would generally provide the same kind of needs. And then there's the apartment style community, kind of like Mountain Vista here, where you'll have multiple apartments in one building, a communal dining space, communal activity spaces, etc. Paid for, assisted livings could be paid for privately, obviously, using our personal funds. Long-term care insurance can also be a nice benefit to these. However, some long-term care insurances do not cover assisted living. Sometimes those policies may only cover certain types of care. And then there are some assisted livings that do accept Medicaid. Most of those would be done in a shared room with one other roommate, most likely. Next, we've got assisted living with memory care. Very similar to that of assisted living. Almost everything that we saw that is done in an assisted living setting could be done in a memory care setting. But really the main difference there is that it's a smaller environment. You've got more staff to fewer residents. So that just gives you more one-on-one time. These would generally be your residents that might have very advanced dementia, maybe mild behaviors. They would not be able to cook their own meals or be safe if they were to leave the community on their own. So generally, this is going to be a restricted environment that a physician would sign documents stating that this is the most appropriate setting based on their exit-seeking tendencies. Assisted living may start closer to about $4,000. Certainly at the $4,000, that would include going up in costs with more care. Assisted memory care is going to go up quite a bit more because it's a smaller setting, fewer staff, more staff to fewer residents. It's going to be a higher cost. So in this case, I've kind of put in there about $5,500 would be a good starting rate for an assisted memory care. That brings me to skilled nursing, also known as a nursing home or long-term care. This is really one of the highest levels of care for seniors. And this would give them more physician oversight. In a lot of our cases, many of our residents here in our skilled nursing facility see a doctor almost every day, if not multiple times during the week. There's always going to be registered nurses, LPNs, and CNAs 24 hours a day, 7 days a week. They would also help to pass and administer medications on the LPN and RN side. And then CNAs, which would be your certified nursing assistants, would provide personal care, such as bathing and incontinence care. A lot of times in a nursing home facility, we tend to see a lot more end-of-life care. So we partner more with your hospice organizations, kind of like LumaCare. It's also a much smaller setting. So a room could be private or it could be a shared room. We see because of the higher cost and the lack of mobility that comes out of people that come to skilled nursing facilities, bigger is not better. So having a smaller area to mobilize around and get your care tends to be a better atmosphere. As we increase in these care needs, there is a lot more regulation, both on the state and federal agencies. So at the founding in 1964 of Medicaid, a lot of regulation around nursing homes. It is highly, highly regulated. Everything that we do is pretty much reportable to the state and federal agencies, as well as Medicare and Medicaid. Costs for this could be paid in multiple different ways. Privately paid certainly could be one method, but because of the costs being about $8,500 starting price point in Colorado and working higher certainly for a private room, personal assets can be spent down quite rapidly. And so Medicaid tends to be acceptable in most of these nursing home communities. Long-term care insurance could also be a factor for helping to pay for some of that. Lastly, in a nursing home or long-term care facility, there's often rehabilitation alongside. This is really more of a short-term stay versus the long-term care need we just discussed. Short-term needs for rehabilitation would include physical therapy, occupational therapy, speech therapy. All of these, of course, really looking to advance the person potentially for a discharge back home is in most cases what everybody would want. These are generally covered under Medicare. A lot of when we see a person come in for rehabilitation, it's due to a surgery or weakness, or they've had a decline in their health. And when we see that, they usually come to us on rehabilitation covered. There's no out-of-pocket cost usually during that time. Now, starting day 21 through 100, that can range, and it varies. Medicare, Medicare Advantage plans, private insurance, those kinds of things can certainly change how much it would and beyond. And in some can cover these at 100%, essentially covered at 100%. So this would be covered by Medicare, private insurance such as your Cigna and United Healthcare, Kaiser, etc. And occasionally people do privately pay with their private funds. I'm going to now open it up to all of the questions that we've received from everybody here. Let's see if we do have any questions for some of our participants. So it looks like one here was, we had discussed home care in, it kind of crosses into several different ones. So this one's going to be for you, Saul. Where does home care stop and home health begin is the question that's being asked here. Saul, would you mind taking that one over?
Sure, and I probably will have Joan jump in to help with the question. Great question, by the way. So where we talked about where it can obviously start in the home or independent living community, and where it starts, where it ends, it can continue to go until you need additional help with some of those ADLs we talked about, where, for example, shower assist or dressing assist. When you feel that is happening more than you can afford, for example, 4 to 6 hours is affordable, but when you need that help, twice a day, in the middle of the night, and your coverage for in-home care, those costs start to go up, then it really makes sense to start talking to an assisted living community like Jason's community or others about the 24-hour care. So that can happen in any given day, whether it's a couple of weeks with in-home care or a year or 5 years. So that's just a matter of when those ADLs start to change and need more care than 4 to 6 hours, and the cost of that care starts to go up. So that's usually a time when it ends. But keep in mind, though, we do integrate and work with home health. So when they start and stop, I would let Joan answer that. But a good example would be when, let's say, we're working together with them on a post-op stroke patient. We may come in at the end of 1 month or 2 months when their care ends. But Joan, could you comment on when you would start and stop your services?
Yeah, generally speaking, we're going to start when the skilled need is required by the physician, and that can range from many diagnoses, whether you've had surgery, you're having some forgetfulness, you're having you had a fall. We can do a fall prevention program. You've got COPD, and we need to come in and monitor medications. So generally speaking, you don't stop home care and start home health. It can be a parallel line, and it can be that we come in and we assess the situation, because again, we assess your home safety. is your laundry upstairs in your bedroom? We're able to assess your house and move your living space onto the first floor, but now laundry is upstairs, or maybe your kitchen is upstairs where you cannot get to it. And so that's when we might suggest maybe we'll have a social worker come in, or maybe our therapists or nurses can just talk to you about the options of different plans of care. Maybe having home care come in to help with meals and laundry twice a week. They can make 3 or 4 meals and leave them there, and you just need it for a short time. We will probably pull out at the time when there's no skilled need. So you've reached maximum potential to your goals. Encompass always tries to focus on what your goal is. And when we've reached that maximum potential to your goal, then it's time to start looking at next steps. And we always have that conversation before we leave, making sure that you're safe before we leave.
Great question. Thank you both for your answers on that. We just have one other question here, and this one's going to be for Ali Lumacare, if you're still on with us. The question asked is, we discussed that a person may have an end of life makes them eligible for hospice care. That is when a physician 6 months. The question is, at 6 months, if a person hasn't passed, are they kicked off of hospice care?
Absolutely not. So as long as they're meeting that Medicare criteria, they can stay on hospice. We've had patients that have been on hospice for a couple of years, just because they have that, gradual decline, and they're still meeting the criteria. So they don't get kicked off of hospice care as long as they meet that criteria.
Great. Thank you again on that, Ali. On here, on your screen there, you've got the contact information to all of our experts here today. I wanted to give a big shout out to everybody here today, Saul, Joan, Ali. Thank you all for your time today and really giving us a good understanding of all the different levels of care and senior care options. I do suggest, if you have any personal questions yourself, reach out to each of these individuals directly, as they are the experts in their field.